Oh, hey, Chris.
Hey Chuck, how are you?
I'm doing great. How are you this fine Sunday morning?
Oh, well, I'm inside on a beautiful Sunday morning, but just finished rounding. It's interesting. We have this policy now where, we have to, attending physician must see the patient 7 days out of the week. And it's really nice to actually not sit, but actually walk around with the resident and talk to the resident. I feel like that's probably the biggest perk that I've noticed. Obviously, the patient care part of it too, but just a little downtime with the residents is kind of fun.
I think that resonates with me on two counts. One, I totally agree. I don't love going into round. That's why I went into hand surgery, so I didn't have to do that much. One of the reasons I went into hand surgery, but hanging out with the residents and getting and rounding is okay. And honestly, I don't think we're adding much to patient care, but occasionally we might. But the second resident point is you and I have been doing what we old school called the resident fellow clinic and attending there. And I have to say that has been fantastic. I really enjoyed that. It's just a very different environment in the sense that the residents and fellows, quote unquote, own the patients. I'm there for consultation, and I love that environment.
I enjoyed the last time I was there, mainly because I brought snacks. It's very, it was great. I did that. I remember I did that clinic as a fellow here, and it was a very important part of my experience, and one that I wouldn't trade for anything. And I think having some additional attending involvement in whichever way is useful to the trainees. The residents and fellows do a fantastic job in that clinic, and they clearly show ownership and they value that. And just be a small part of it again is nice. At rounding this morning, of course, all the things that happen when you round happened. So first patient we went to see had just gotten into the bathroom. Another patient that we were going to go see was literally getting transported as soon as we got to their bed. So I won't say it was the most efficient rounds. And then, of course, somebody got added onto our list to see right at the end. So, but it was fun. Joe Givian is actually, I think, on your service right now, and fantastic resident, a lot of fun to work with. And yeah, it's a nice thing. Yeah.
Yeah, those are the frustrations of rounding, and when you're trying to, take your time and be, teach, and then you get stymied at every turn with a hiccup. It can get a little frustrating.
What have you been up to otherwise?
This week has been re-entry. I was fortunate enough to go away with the family on a wonderful vacation, as I think you did as well, and had a wonderful time, and come back and just get back in the game. And it was a good week clinically. Very busy, as most of us are when we come back. You get busy before, you get busy after. It'll take me a couple weeks, I think, to catch up completely. Yeah, how was your first week back?
It was good. Pretty much the same. Was a little surprised by how refreshed I felt after traveling with children, young children. It's a bit of a hit or miss, not exactly vacation, but there was some relaxation and some recharging. So I felt pretty good coming back. So any interesting emails that you've received recently?
Sure. I mean, a couple really. I have to pause. The first, oh shoot. It's going to take me a second. I'll have to clean this up. Okay. Yes, I've gotten a couple of really interesting emails lately regarding the podcast. The first one was from Andy Nelson, who is a Hand Study member, a listserv participant, and he wanted to follow up and discuss a little bit more about technique for arthroscopic TFCC repair, specifically foveal repair. And this was in response to our deep dive on surgical technique. And we had a good email conversation. And I have to say, Andy is in New Britain, Connecticut. And while I've known him for a long time, I don't know him super well. But I was happy he discovered the podcast. And it's always, it's just so interesting how this podcast is becoming more and more, people are becoming more and more aware of it, but at very different time points. And second of all, that he became aware of it. He has a long commute. He's been enjoying listening to it. And I love the fact that he followed up with questions.
Questions are always welcome. So if anybody has any questions, feel free to email them to handpodcast@gmail.com or leave them in a review. But yes, Andy, thanks for listening, and thanks for spreading the word on the listserv. I know that we've gotten a little buzz on there, and the listserv is a fantastic resource for many practicing hand surgeons and trainees. So what was the question that Andy asked you about your TFCC repair?
So I'm going to just quote him. And I kind of love all of this. He said, Chuck, I feel via the podcast I have come to know you enough to call you Chuck with all the respect you deserve. Well, I don't know if I deserve any respect, but I certainly welcome the first name basis. And then he said, first, I love the podcast and just discovered and have binged on my 35-mile commute to and from work. I'm working on a list of suggestions to come earlier. Thank you. We want suggestions, and we look forward to that list. And the question is, I don't think I understand exactly how you do your TFCC repair. And he has done an open repair, which sounds like it's pretty much like mine. And then we went back and forth on the technical. And I think that bears further emphasis. So there are sports hand surgeons out there, and Steve Shin is one of them. Steve is at Cedars-Sinai in LA. Steve is clearly recognized as a sports surgeon. I think you are going to or have just recently interviewed Steve for your podcast. But Steve does an open repair of TFCC injuries with a suture anchor for foveal type repairs. And he has a slick technique and is very pleased with it. I really like the arthroscopic repair. I believe you get better visualization. I think you can be more technical with your suture placement. And so I think you could accomplish the same goals, and certainly, surgeon comfort is incredibly important. It remains my preference to do these arthroscopically.
Do you consider your ulnar tunnel technique to be an arthroscopic repair?
So that's super interesting, and that may tie into another conversation we have. I consider an ulnar tunnel, that is, drilling a short oblique tunnel through the ulna and bringing the sutures down and tethering the sutures to the bone, to be an open assisted technique. So, the scope is in the joint the entire time. The scope and a probe are helping to assure exact placement of the sutures, but ultimately this is an open repair technique. And so I think it actually checks both boxes, and the coding is interesting for it.
Yeah, well, that actually brings us to probably our topic of discussion for today, but I love that technique. And mainly because I think you were doing it with more frequency when I was training with you, or you just started to do it more, and I really like it, and it's worked for me as well. And it's pretty intuitive. So perhaps one day I should really sit down with you and kind of go through a true open technique, but if I'm in that kind of setting, I'm probably sending that patient to you anyway.
Well, I appreciate that. I'm in the middle of a study. I don't think that foveal TFCC tears, and I guess I should broaden that, the wide expanse of TFC pathology, I don't think is super well understood. And maybe it's not well understood by me, but I think it's taken me years to really feel like I totally own it. And I think I do. But my sense is that if we took a couple of surgeons from WashU and a couple of surgeons from elsewhere and compared our assessment, it would not be the same. So that's what we're about to do. There's one study out there doing this out of Philadelphia. We're going to do it on a little bigger scale. We have about 40 arthroscopic videos, and we're going to compare and contrast and try to see what people think about the diagnosis. Because you can't make the diagnosis in a way that is mutually agreed upon by all, then obviously the treatment's going to be very different. So anyways, understanding the TFCC tear is the first step, and then surgeon choice on treatment thereafter.
I think your study's going to be really interesting. I can't believe you're giving away all of your wonderful study ideas on the podcast.
Hey, more power to the listener who can make this happen quickly. I'm all about other people jumping in. This is a tough one though, to get good videos and reviewers. It's taken us some time.
Yeah, I mean, there's some really interesting literature in parallel in the general surgery education space along these lines, not necessarily grading and assessment, but also surgeon skill in terms of sending in videos of your laparoscopic cholecystectomy and seeing how efficiently you move and having somebody else grade it. And they might have even incorporated something like that into their board certification process. I mean, I think it's super interesting. And, Funny enough, somebody emailed us saying that we both say super interesting a lot. So I just caught myself doing that.
We
You've got your
do.
two things and we both have our super interesting.
Well,
But yes, super interesting space.
yeah, well, it's not just interesting, it's super interesting. I think that's fascinating. And we have had a brief discussion, I think early in the podcast about how do we continue to improve as surgeons if we're not, coached on surgical technique and individually assessed. And your comment gets to the point of that, which is a whole nother level of discussion, but fascinating.
So to continue with our mailbag theme for today's episode, there was a great email from Cal Shaw, who has listened to the podcast for a long time, and we appreciate that, Cal. And he emailed, it was a little bit ago, but a question about coding. And he was talking about how we code potentially for a ganglion cyst. Do you code for an arthrotomy? Do you do anything for a capsulorrhaphy? And then just in general, just some discussions about coding and thoughts. Do you have any thoughts on that, Chuck?
Yeah, if I may, I think, and this is something, and judge me if you must, that I enjoy. I think the coding process is interesting. It's certainly controversial, and I know we both want to touch on a recent study in JHS Go, but I think coding perspective, unfortunately, is colored a bit by practice setting. And probably, honestly, not surprising to understand that. But surgeons who are reimbursed based on RVUs or collections code more aggressively, if that's the right word, and salaried surgeons are less likely to do so. And that obviously is not the way it should be, but I kind of understand it. I think, you and I are certainly in an academic situation, but we are reimbursed based on collections and RVUs. And so we might be thrown into that latter group, although I think we both take this seriously and code carefully, and certainly don't want to overdo it. So before I jump into this specific example, we can pick a few. What do you think about that general statement? Does that resonate?
Yeah, I mean, I think yes, it's really important for the listeners to understand our context, and the fact that we have base salaries and then we are additional compensation based on collections and RVUs and that kind of thing. I'll be honest with you, I don't pay attention to it as much as I probably should. I know I should, but I don't, and it's one of those things where I do the work, I dictate what I do, and I kind of just let the coders do their thing. I probably should pay more attention to it. Like, for example, like when David Brogan and I do a plexus together, I trust him to tell me how we should split everything up because he knows all this stuff. Because either he is interested in it, or I think in his prior practice setting when he was at Mizzou, he paid closer attention to it. I honestly don't want to get into the weeds on that. Again, knowing that I should know more, but there are many other things that I have going on in my head.
So let's be clear for residents who might be listening and fellows who might be listening, even young, attendings who might be listening. Ultimately, you can have coders, and many of us do, but ultimately it is your responsibility to code correctly. And, fraudulent activity, intentional or not intentional, comes back on you. So Chris and I are very fortunate that we have a wonderful group of coders that are subspecialized, but I review my codes every month, and there's never major issues, but I would say 10% of the time I have a question or we have a subsequent discussion about coding. Again, simply because I like it and want to get it right. I do strongly feel that, we as doctors and we as surgeons are entitled to reimbursement, appropriate reimbursement for the work that we do, but no one's going to hand it to me. And so I have to be prepared to ask for it and get it. And I feel really strongly about that. And I think, this silly process of coding is part of the game we play, and it is a game.
So to quote you, two things, as mainly as questions, but
that's super
I just wanted to get
interesting.
that two things. So put on your hat as vice chair now. What percentage of our surgical faculty do you think actually go through the process that you just described of looking at your codes every month?
Geez, I wonder if I should disclose this, but I will say conservatively, it is less than 1 in 5 who do this every month. It is and again, we all choose different practice settings for different reasons. The protected environment of academia is no longer what it used to be, but some of it is. Some of it is I just don't like dealing with this. I have lots of other things on my plate, but it's a minority of us who actually look at the coding and double check it prior to submission.
Yeah, I mean, and there's incredible variability or heterogeneity in how we all would code something. I've seen, and at least I don't know how it goes in terms of the codes, but I've seen different, for example, in peripheral nerve, I've seen different surgeons at our institution, how they list out their procedures. And I don't know, again, if they're all getting coded the way that they're getting listed in the op note, but for a nerve transfer, listing out an internal neurolysis in addition to the nerve transfer itself, in addition to decompressions and all the other stuff. So, I mean, there are a lot of ways you could do it. I mean, yes, technically that is part of the work, but, ultimately what is supposed to be included in that one single code for a nerve transfer?
So great point. I want to emphasize 2 things. The first is that, and I think this is going to make you feel better about your choice to not review this, but our coders read every word of every op note. It's unbelievable to me. It's not like they're reading what our procedure is. They're reading our procedure and making sure we justify it. I mean, it's awesome. The second is the Hand Society has a global services guide, which I don't know the last time it was published, and maybe we should reevaluate it as an organization. But it is wonderful. So it takes every CPT code. So for example, let's say one of your favorites, 64718, so ulnar nerve, decompression, or transposition, and it lists out what's included in that code and what's excluded in that code. And again, for those of you starting out in practice, it's really helpful to have that as a resource to make sure you understand that you're not unbundling and you're coding maximally appropriately to get what's due to you.
So I never got to get to my second point of my GoFarv thing. You said, there are maybe 10% of cases or something that you review that maybe there are some questions on how it was coded. What are usually the issues that come up? Are there any common themes?
Yeah, I think well, again, I don't want to keep referring to a paper we're going to discuss, but there are a certain percentage of codes that are super straightforward. Although maybe not straightforward as I thought, but like carpal tunnel release, 64721, no problem. We all know what that is. I think it's when we get to the unusual things. And in your example of a plexus procedure or a nerve transfer procedure, it is certainly one of those. That's when things get a little hairy. So for me, it's when I do a procedure that none of the 6, about to be 7 of us, do on a regular basis. That's a little outside the box, that just needs clarification. And sometimes I question it and I'm wrong because the coders have thoughtfully considered everything, and sometimes I'm right. The other issue are unlisted codes. And so that might be a CMC arthroscopy, or, there are codes for small joint arthroscopy, but those things are not coded regularly. So you need to find comparison codes, et cetera, et cetera.
So Cal asked about common surgeries and how you would code them. So how would you code a submuscular ulnar nerve transposition?
Yeah, and then I'll answer this one. I want you to answer this one. Then let's go back to the dorsal wrist ganglion or wrist ganglion of his original question. So for a submuscular ulnar nerve transposition, I would code 64718. That's addressing the ulnar nerve, and I would code lengthening of the flexor peroneal mass 24305. And so I happen to do a Z lengthening of the mass, but cutting and repairing the flexor peroneal mass, to me, merits a different code. I don't code for anything else, any other add-ins. I don't really think others do. And this one, I'm sure I'm wrong. I'm sure there's some people who hopefully will comment, but those are the 2 basic codes for me. What about you?
How frequently do you think you get the reimbursement for the Z lengthening code?
Isn't that a fascinating question? And as much as I'm interested in this, I do not know. But the coders continue to agree with that approach. I am assuming, shame on me, that they agree because they know we do get reimbursed for both codes. I don't know the answer to that question.
Now, I've heard through the grapevine, through our trainees, that I have converted you to doing a subcutaneous transposition with the fat pad flap that Mel Rosenwasser originally described. When you do that surgery, you can't bill for the flexor pronator lengthening because you're not doing a submuscular, you're doing a subcutaneous transposition. Are you just 64718 there, or do you think that our coders are adding anything else for that pedicled adipofascial flap that you're creating, pocket to put the nerve in?
So first of all, hats off to you and Mel. I have become a
Not me, just Mel. That's Mel's technique. I just like it.
Well, you converted me though. Hats off, because I really like it. And it doesn't work for every patient based on the volume of subcutaneous tissues and the adipose cutaneous tissue. It is fantastic. It is a game changer for me. And maybe you should talk through it a little bit just to reinforce it. I absolutely love it. I never loved the Eaton Flap, which is the dense fascia, which was described many years ago, 50 years ago. The problem with the Eaton Flap, in my humble opinion, is that it is a kind of rigid structure against a nerve. The exact positioning of that flap is dependent on the repair into the subcutaneous tissue, so it can theoretically be compressive if you're not careful. And it also tends to medialize the nerve, and if you're not careful, can put the nerve up against bone, which the nerve doesn't like. So for those three reasons, I don't like it. This adipocutaneous flap is fantastic. And that's a very long answer to your question. I only bill 64718 unless you are going to tell me I should be billing something else, but I just do a simple 64718.
I mean, in theory, it is pedicled, and it's adipocutaneous, adipofascial. It's how I describe it. I'll be honest with you. I list it as that. I have no idea whether it gets coded or not. And I feel so bad that I don't know, because you're like looking at your codes every month and I'm like, la, 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 I'm just living my life.
Well, I mean, we got to, I think, listen, I hope there are listeners who will help us and tell us what they do in this code. And that's a great question. And again, I am grateful. Do you want to give a 1-minute description of exactly how you tackle this? Because what, I know you want to talk about nerve.
Well, I guess the first thing I'd say is I probably should email our coding team, and they are fantastic. And just asking them, that would be my homework. And then there are probably our private practice hand surgeons are like, these academics are such dopes. at least that D guy. I like that. I like that technique. It's based on an article from Mel Rosenwasser at Columbia. And instead of doing whatever version of a fascial sling, you're taking that very nice pocket of fat that sits basically right on top of the intermuscular septum and extends a little bit distally. Now, you got to be careful about your MABC in that area because it does tend to cross obliquely right around there. But I elevate as wide of a pocket of that as I can. And depending on the anatomy of the patient, I either split that layer longitudinally, like you're cutting into a bagel and you're opening it up and put the nerve in there. Or if the anatomy doesn't allow for that, I will take that layer of fat and then sew it to the posterior soft tissue, and then after bringing the nerve to the front. And that's how I keep it. I mean, so the important part there is just a really wide pillow for that nerve to sit in. And again, it really depends on the patient's anatomy. I think that, knowing how to do an Eaton sling or whatever type of sling you need to do is important, just because you never know what's going to be available to you in a revision or a revision of a revision. So I whenever we do these, I tell our trainees that you got to know how to do every type of transposition, just because you never know what you're going to have to do. Because, like, for example, I won't go submuscular if one of our partners or I am doing a elbow contracture release at the same time, because I don't want all that swelling and inflammation from the joint to be right on the nerve. And then you have to tuck the nerve somewhere else. So I digress. I can't believe you let me talk about nerve for even a little bit during this coding episode.
No, it was self-interested. So thank you. Maybe you can send me the exact article and I can put it in the show notes for that one.
Absolutely. So let's get back to the ganglion question.
So to me, and again, I hope our listeners aren't totally rolling their eyes. A ganglion excision is straightforward. And yes, you are doing a capsulectomy, and some might even do a posterior incision neuroderectomy for a dorsal ganglion. I hope not, because I don't think it merits that. But
That's aggressive.
I know. For a ganglion excision, it is a 25111 for me, whether it's a dorsal ganglion or a volar wrist ganglion, and that's it. Nothing else. What about you?
Now, say you're doing a volar, and it's because I've encountered this. I've done a revision or of recurrence or whatever, and the cyst is literally plastered on the radial artery. Is that like an arteriolysis code or what? I don't even know if that exists, but there is quite a fair bit of work that sometimes comes with getting the cyst off of the artery if you choose to do that. I know some don't, but
Yeah, and I guess in my naive academic brain, I think that it all evens out in the end. And so some of these will be super simple and super fast, and others will be a little more challenging and will require arteriolysis, so to speak. There is, however, as you know, a separate code for a recurrent or a revision ganglion excision, 25112. But yeah, for me, it's very simple, one code. And for carpal tunnel, it's one code. I think other people might do some different things based on this article. You want to briefly discuss the article?
yeah, sure. I mean, so this article is let's pull it up here. It was in JHS Go, and it was last year. It's from the group at NYU. Steve Glickel is the senior author. First author is Ryan Coyle. So thank you, Ryan and Steve, for bringing us this article. It's called Coding Practices in Hand Surgery and Their Relationship to Surgeon Compensation. So sent out a survey to Hand Society members, and they got out of over 4,000 invitations, they got a 9% response rate, which is actually pretty reasonable. And then they asked them how they would code a thumb CMC surgery or trapeziectomy and a distal radius case. And then they looked at how the surgeons were compensated and whether they did their own coding, et cetera. And it made a difference. So if you are a collections-based surgeon or an RVU-based surgeon, you definitely code differently than if you're salaried. And I guess that's not surprising. I think we kind of talked about that early on.
Yeah, I don't think it's surprising. It's not appropriate that it should be different, but it's not surprising. Let's go through these. So the first was carpal tunnel release.
Oh, right. Yeah. Mm-hmm.
And the CPT code that the vast majority of people provided was 64721, which I think you and I would totally agree upon.
Mm-hmm.
But there are others included, some of which surprised me. Synovectomy was given as one that might be included. I was always taught that if you do perform a synovectomy, that supersedes the carpal tunnel and you don't bill both. Internal neurolysis. Gosh, I didn't think anyone was doing that anymore based on McKinnon and Gelberman's separate work showing that wasn't necessary. So people add on different codes, and I just have never done that.
Let's be very clear. Anybody listening as a trainee, you should not be doing an internal neurolysis of the median nerve if you're doing a primary carpal tunnel release. So maybe there are some situations like a revision or something like that where you actually do need to do an internal neurolysis, but not in a primary carpal tunnel release. I was told always that, I do a lot of local, and I was told you're not allowed to bill for that local, but it looks like there are some people here that are billing for the local anesthesia that's provided. Either, I don't know whether that means that they're doing it as part of their Wallant, like beforehand, or whether they're doing that as part of maybe like a post-op administration of anesthetic.
My education was the same as yours, that we are not, the anesthesia is incorporated as part of the code. Getting back to that global services, 64721 includes anesthesia pre and post, I think. Again, correct us if we're wrong. Interesting.
Yeah. So the next one that they looked at was distal radius fracture fixation. And there are all sorts of codes that were included. I mean, most people went with 25607, which is, treatment of an extra-articular distal radius fracture. I think that there are many ways to justify intra-articular involvement based on whether it's many of these fractures are really metaphyseal based, but do extend into the radiocarpal joint. I've seen some people justify extension into the sigmoid notch as an intra-articular fracture. So I think maybe there's some room for interpretation there. Another code that was often billed, and I want your thoughts on this, was the fluoroscopy. I know that that's one point that you feel strongly about. And then the other application of cast, which I think is interesting.
Yeah, so application of cast is not something we should be billing for. That's part of the global services. And then the other one I think is release of the brachioradialis
Yep.
is incorporate tenotomy. So BR release again. To me, that is, I guess, in my mind, less egregious than billing for a cast application, but it's just part of the procedure. It also takes 10 seconds. Now, someone who sees this process differently will say, we are doing this, we should be compensated for it. And that's just a difference in philosophy. However, I think if you use a mini C-arm, then it is very appropriate to bill for that and collect for it. So we don't own the mini C-arm machine, but we can bill for the professional fee. And actually our radiologists agree with that, even if they review them later, because this is it would be inappropriate for me to consider a radiology partner 12 hours later reviewing and billing for an intraoperative, C-arm assessment. So I think it's very appropriate. There are rules and regulations on how you do it. You have to dictate a separate note, talk about the views you obtained, and talk about what you saw. But I do feel strongly that is very appropriate.
Yeah, I mean, I dictate a separate note or a portion of the operative note for the fluoroscopy interpretation, and then in the clinic, I'll also put a separate note in for the mini C-arms. I mean, I don't know, it's obviously not a ton from an RVU perspective, but as you've mentioned, it adds up over time.
It does. Yeah, it's usually $25-$35 or something, but given our hand surgeon profession, it's something we do regularly.
So did you want to talk about either the trapeziectomy one or the scaphoid case before we wrap up?
The scaphoid, I think, will be super easy. I think most of us for a scaphoid non-union will build 25440, which does incorporate bone grafting. So again, it's one of those where I'm a little surprised there are other codes being included.
Like a bone graft code?
Like a bone graft code. The other one you can't include, not that it was done here, is if it's a non-union and you take out a screw and then you're revising fixation with bone graft, you can't bill for that screw removal. But yeah, you can't bill for bone graft here. The interesting one, as you mentioned, is the trapeziectomy. And we in the Hand Society actually knows this. We're all over the map on how we bill, and that's what this paper does demonstrate. And you and I have had to modify how we think about it because we are generally using a suspension plasty with a internal brace, or whatever you want to call it. And so previously I used an FCR, kind of the classic procedure, Burton and Pellegrini style, and I used FCR, and I did bill for that, the 25310. But now I am doing something that I think is better and more patient friendly, and I'm billing less. I'm doing less work, but I'm billing less. And so I just billed 25447. How do you think about it?
I think the same way. I mean, I think that, yes, we're all over the map on coding because we're all over the map on what to do. There's no right treatment for this. And yes, we probably should, be billing less because we're doing less work. And this is supposed to be, relative value units of work. So yeah, I think it's fair.
Excellent. Well, this is fun. As you know, I like this, and I like listener questions, and I hope and think we're going to get some feedback on this one because this will resonate with many. So fun topic.
Yeah, please tell us how we can code better, and maybe I'll start paying more attention.
Yeah. I'm going to take your role here. What's your win for the week?
My win for the week is actually the kids getting in the pool and me paying way too much to heat the pool in this weather. But yes, the pool is sitting it'll be a lovely 80 degrees by the end of the afternoon.
My win is vacation. It is indescribable and mandatory, and it's felt like a long time coming. And I was really good this vacation. First of all, I was grateful that my entire family could join us, and I really didn't open the computer much, and it was great. Fantastic.
I'm sure you snuck away at 4:30 a.m. to check your email.
Once in a while.
If they don't know about it, it didn't happen, right?
That's right.
Well, have a good rest of your day.
Yeah, you do the same. Take care.